Moving on to the next topic, Dr. Amit Sanghvi will be speaking on antiplatelet critical review. Dr. Amit.
Hi, good afternoon. So I think this is an interesting topic because we see these patients in our clinical practice very often. So at the outset, I would like to thank Dr. Satyavan Sharma sir and Dr. Dev Pelajani sir for giving this opportunity, and welcome to all the out-of-station faculty here. So we're going to talk about antiplatelet therapy in patients post-PCI who are going to undergo non-cardiac surgery. So we know that, this is the data from Indian NIC registry. We perform 4.5 lakh interventions every year. Patients who undergone PCI will require some non-cardiac surgery at some point of time. The incidence is about 4 to 8% in the first year. This increases to about 23% at 5 years. The important thing is the first year, because we know that discontinuing antiplatelet therapy in the first year can have deleterious outcomes. So we're going to concentrate in the first, what happens in the first year. We have this data, everyone knows this. We have multiple trials where they have shown that use of DAPT post PCI, irrespective of whether the patient is an ACS patient or stable ischemic heart disease patient, generally has beneficial effects. The MACE is less, ischemic events are less, and generally we recommend using DAPT in all post PCI patients. At the same time, we have data to show that withdrawing DAPT early can lead to deleterious outcomes. There is increased incidence of stent thrombosis, there is increased incidence of MACE, and we want to avoid that at all costs. Now, so what do the guidelines talk? How long should we use DAPT ideally in our patients? So it said, so if you look at the ACC guidelines, they say that duration of DAPT post DES implantation should be 1 year for a patient who suffered from an ACS, and should be at least 6 months for a patient who has undergone angioplasty for a stable ischemic heart disease patient. Now this can be shortened by 50% if required, if the patient has overt bleeding or patient becomes a high bleeding risk patient. Otherwise you need to continue it for 6 to 12 months depending upon the patient's presentation. Now why is surgery so important? Why are we so worried about surgery and the clinical outcomes? So surgical procedures, we know they are pro-inflammatory, they create a hypercoagulable milieu. This is because of so-called surgical stress response, where there are multiple inflammatory cytokines which are released in the circulation associated with increased sympathetic activity, can cause increased shear stress on the vessel, and this can lead to plaque ruptures in ACS. So when we want to discontinue antiplatelet therapy around surgery, we need to be even more careful. At the same time, sometimes surgeries are inevitable. So you can classify surgeries depending upon how urgent the surgery is. So there are some patients where the surgery is emergency, you need to do the surgery at that point of time. It can also be urgent where, you have to do it as soon as possible, but maybe you have few hours to decide what you want to do. Or some surgeries are time sensitive. For example, a patient with malignancy in early stages, maybe it gives you about a month to decide and to plan your surgery, to stop your antiplatelet therapy. And finally, elective surgeries are those where you have a significant amount of time. And this is where, especially if you have performed PCI in the last 1 month, you can definitely delay these surgeries because these are not emergency surgeries. So when we use DAPT post PCI, we know that this is a trade-off. So in giving DAPT decreases ischemic events, but there is always a small increase in the risk of bleeding in these patients. And what we need to understand is what is the optimal duration of this DAPT, below which you cannot discontinue DAPT in this group of patients. So it is clear that intimal healing is what we look at. And if you do POBA, the intimal healing takes about 2 weeks. For bare metal stents, it's about 30 days. We don't really use BMS anymore in our clinical practice. DS, it's almost 3 months, and it can be as high as 6 months in the first generation stents. And for drug-coated balloons, so we are now using more and more DCBs in our clinical practice, and this is at about 4 weeks. Now this is very well incorporated in this study which was published by Thompson et al. Recently in JACC, where they say that optimal timing when we look at surgeries, time-sensitive non-cardiac surgeries or elective surgeries should be postponed for at least 2 weeks if the patient has undergone POBA, should be postponed for a month if the patient has undergone a BMS implantation, and should be postponed for 6 to 12 months post-DES implantation depending upon the clinical presentation. However, you can shorten it to 3 months, but if you want to perform this surgery below 1 month, we need to keep in mind that the risk of ischemic events are very, very high, and therefore it is generally recommended that in the first month post-PCI, do not do any surgery. If it's possible, please defer the surgery beyond that. So let's look at this particular case scenario which we had in our clinical practice, 66-year female, anti-wall non-ST elevation MI, fairly preserved LV, underwent angioplasty to LED, developed severe constipation, was admitted about 7 days post-procedure, was diagnosed to have an anal fissure, but was treated conservatively because this was too early to do any procedure for the patient. Went home, came back in 3 days with severe constipation, needed manual extraction of stools, had some bleeding, and the surgeon now wants to perform surgery because the pain is too severe, and I mean the patient is just not doing well. The problem is this was about 3 weeks post the surgery, and then how do we kind of do this? Do we still postpone the surgery? The surgeon was not willing to postpone this surgery, neither was the patient, because the patient was in terrible pain. So we'll look at this again a little later. So whenever we want to decide about stopping DAPT, we should look at the thrombotic and the bleeding risk. The thrombotic risk depends upon multiple factors. Stent type is definitely important. The newer generation stents do better when you stop DAPT. Time from PCI we shall discuss in the future slides. Angiographic features and clinical features are important. So if the patient the presentation is an ACS presentation, patient has LV dysfunction, patient has kidney disease, then these are the patients who are at high thrombotic risk. Angiographic features, so if you you've done a very complex angioplasty, 2 stents in a bifurcation, a left main plasty, multiple long stents, these are the patients at a high thrombotic risk. The bleeding risk depends upon, of course, the anesthesia used and the surgical procedure. So anesthesia used, the point to be made here is that regional anesthesia and neuroaxial anesthesia, where you want to use their spinal anesthesia, is a problem when the patient is on DAPT. There have been case reports of spinal hematoma seen, and now it's not recommended to continue DAPT, especially if the patient is going to undergo a spinal anesthesia. According to type of surgery, so you can have some procedures like dental extraction, you can have something like a cataract surgery which has very minimal risk of bleeding, and you can definitely continue your DAPT. On the other hand, you have surgeries where the risk of bleeding is very, very high, such as intracranial surgeries where even a small bleeding can be deleterious at the same, or extensive malignancy surgeries, biopsies of vascular organs. All these carry a very high bleeding risk, and these are the patients where you will have to stop at least one antiplatelet therapy. Again, thrombotic risk, like we've discussed before, depends on the time from the surgery. So more than 12 months post DES implantation is considered to be low risk. Between 6 to 12 months is intermediate risk, and less than 6 months is very high risk for stent thrombosis. So what we are going to look at in detail is the time consideration, is the consideration of time from PCI, whether the angioplasty was was done beyond 1 year, between 3 months to 1 year, or less than 3 months. So beyond 1 year, we know it's safe to withdraw the P2Y12 receptor inhibitor. In most of the cases, you have to continue aspirin, except in very few situations where you may have to discontinue. And the MACE rates, the stent thrombosis rates are minimal beyond 1 year. So this was a recent study, the ASSURE DES RCT, which was published in JACC recently. And here they were low to intermediate risk surgery patients, stable patients who were randomized to aspirin monotherapy versus no antiplatelet therapy. And at 30-day follow-up, there was absolutely no difference in the two, no increase ischemic event seen even without aspirin. At the same time, the minor bleeding risk was a little more. The problem is that this was an open label design study, the stable patients, low to intermediate risk patients, and more importantly, no biomarkers were done in this. It was a pure clinical follow-up. So even if the patient had small events, this was not recorded in this particular study. In spite of these limitations, we need to understand that post 1 year, if you have to stop even the second antiplatelet in low risk patients, it is possible to completely go off antiplatelet, and this may not have deleterious outcomes. You have similar data from the Paris registry, where again they have said that if it's a physician directed discontinuation of antiplatelet therapy depending on the timelines, or if you have a short interruption of DAPT for a period of up to 14 days peri-surgery, again if the patient is more than 1 year, there is not much deleterious effects. 30% of these patients had stopped both aspirin and the second P2Y inhibitors, which means again that beyond 1 year it may be possible to take off both the drugs in certain selected situations if required. So what happens between 3 months to 1 year? Of course, if it's an elective surgery, you would like to postpone the surgery to 6 or 12 months depending upon the clinical presentation. If it's not a deferrable surgery, you need to kind of do the surgery early, then probably you'll have to stop the P2Y12 receptor inhibitor, continue aspirin. But if it's more than 6 months, we are relatively in a safe zone. The MACE rates are low, and beyond 6 months, it's not a problem. Between 3 to 6 months, you need to decide what is the ischemic risk. If the ischemic burden, the risk is very high, you might even consider bridge therapy. We shall discuss bridging a little later in this certain selected group of patients. So what happens below 3 months? Below 3 months, again, it's better to defer surgery. We've seen that before, and we have a lot of data. We have data from registries from Denmark and Danish National Registry, where they've seen that if you stop DAPT less than 1 month, the MI rates are very, very high. And below 1 month, both the MACE and the stent thrombosis rates are very high. So it is very clear that you will not stop these drugs below 1 month post PCI. The important thing is that now we have data with newer generation stents like the BioFreedom, the SkyPoint, or the Onyx, and you have data. You have the 2890 study from Zions. You have the Onyx one, only one trial for Onyx, and the Freedom trial from for BioFreedom, which says that at 1 month also in high bleeding risk patients, you may stop the second antiplatelet therapy, and this patient will still do well clinically. So if you have to plan a procedure where patient is going to require a non-cardiac surgery in the near future, probably you can use these stents. You can also use a drug-coated balloon in distal vessels where you can stop DAPT at 1 month. So you can plan your procedure if you are anticipating this kind of a problem. So in non-deferrable surgery, you look at the bleeding risk. If the bleeding risk is low, continue both drugs and perform the surgery. Bleeding risk is high, look at the ischemic risk. If the ischemic risk is low, stop the P2Y12 receptor inhibitor. If it's high, then we think of bridging. So what is bridging? Bridging is it's use of a drug to kind of circumvent the acute ischemic episode, which can happen if you're going to stop one of the P2Y12 receptor inhibitors. Again, the decision of bridging, like we discussed before, depends upon the patient's clinical presentation, the angiographic features, and what is the actual ischemic burden or risk for this patient. So how do you bridge? You can use either GP2B3 inhibitors or IV Cangalor for bridging. You generally stop the P2Y12 receptor inhibitors of 24 to 48 hours later. You start IV Cangalor or GP2B3 inhibitor. Stop it 4 to 6 hours prior to surgery. Perform the surgery. After 6 hours, you can restart Cangalor or Tirofiban, and then kind of load again with clopidogrel and finish this thing. The dosages are given here. The only point to remember here is that the dose of Cangalor used for bridging is very low. It's 1/3 the dose that we use in acute PCI, and the bleeding risk is marginally less in this group of patients. So just a single slide on Cangalor. This is a non-thenopyridine ATP analog, rapid onset and offset of action, no dose no dose adjustment required in renal and hepatic impairment. It's the only drug which is evaluated in a randomized controlled trial for bridging. So bridge trial was a trial where patients undergoing CABG and just 10 seconds more, patients who have undergone PCI or patients who had an ACS are now undergoing CABG. They randomized to Cangalor versus placebo, and the patients in Cangalor did better with no increased risk of bleeding. The only coming back to our patient, we use the bridging protocol. We use IV Cangalor, and the patient did fine. So to summarize, the minimum duration of DAPT should be 6 or 12 months depending upon the patient's clinical presentation. You can stop DAPT at 3 months also if required safely, especially if the patient has undergone angioplasty with newer generation stents. Elective non-cardiac surgery should be deferred till the optimum duration of DAPT is over. And of course, when you don't have a choice, when push comes to shove, you should try to use bridge therapy, because this is what is recommended. Unfractionated heparin and low molecular heparins have absolutely no role in bridging therapy. Thank you so much for your kind attention.
Thank you very much, Dr. Amit. I've got a very small question. We know the guidelines, but unfortunately, the person who is operating, either is a dental surgeon or an ophthalmologist, they are not aware of these guidelines, and they do not take the patient unless they feel that the patient is off the antiplatelet drugs. What is to be done? They will not take the patient unless the drugs are stopped.
Sir, I mean, so if the patient is below 6 months after a DES implantation, then you have to ask them to postpone the surgery as long as it's not an emergency, and you can defer surgery. If we can't defer the surgery, it's a semi-emergency surgery or it's a time-sensitive surgery, then you will have to decide what you want to do. You can stop one antiplatelet drug, continue aspirin, of course, during the entire procedure, and you have to bridge if required, if the patient needs admission for that. So the only other option is bridging and nothing else. So the big trial, Monet Bridge 2, will come soon and probably will have better answer for this. But I think most of the ophthalmologists now are willing to operate on DAPT. So ophthalmology is not a problem. Dental surgeon is a problem. Just ask them to stop clopidogrel 5 days before and just not take aspirin on the day of procedure, and then patient does well generally.
We have got we have got 8 or 9 minutes. Dr. Satwan Sharma, sir. Sir, you can come on the mic, podium mic. Yeah, on the.
Am I audible? Yes. Yeah. So this question is to Amit. Yes. It was a nice talk, and just carrying forward what Dr. Gupta told, many times patients come to us and being in a very multi-specialty hospital where the surgeon has already stopped DAPT. You will see umpteen number of instances where patient has a PCI 3 months back, few weeks back, and it has been stopped. How do you deal with such situations? And I'm sure it is not uncommon in other practices also.
No, absolutely, sir. And I think if the patient has undergone PCI below 3 months, we are in a big soup, because that's where we expect increased stents from both states, especially with the newer generation stents. And then you have to explain to the patient and tell them, okay, look, this is the problem, and at least you have to start yourself on aspirin. If the patient has already stopped antiplatelets and is going to undergo surgery tomorrow, then we've already missed the bus, and then there's nothing more we can do. If the patient has not had an acute event, then we are good. So just give the patient aspirin and probably ask the patient to finish the surgery and then restart DAPT whenever the surgeon is comfortable after 24 to 48 hours. If the patient comes to us for an opinion, probably we'll have to admit the patients and look at bridging if it's very early. That's the only way to do this, because that's the only way where you can prevent an ischemic event. Otherwise, I don't think there is anything else that but because I have patients where, like you said, sir, the surgeon has already stopped DAPT. We've done a plastic 3 months back. Surgeon has said, nahi, band kar do, abhi to ho gaya aapka, and they come back and the patient is already here. Patient is for surgery tomorrow, and he's already stopped DAPT in 7th Zen. He's had no ischemic event. So that's probably nature selection, Darwin's theory, and the patient is doing well, and probably just give the patient aspirin and leave him.
And how often you might be doing the bridging? Because theoretically it looks very attractive, but bridging is practically a problem.
Yes, so because the patient needs prolonged stay in the hospital. So bridging means patient will be in the hospital for at least 3 days pre-surgery, and that's a problem. So the best way is not to bridge and probably postpone the surgery beyond 3 months. But if we can't, then the patient is already admitted. And this is, we are talking about time-sensitive surgeries. We are not talking about emergency urgent surgeries. Because if it's an emergency, patient has a ruptured gallbladder and patient needs surgery, it's a big mess, because then you need to keep the blood transfusions ready, the single donor platelets, and perform the surgery, because it's a life-saving thing. But if you're looking at time-sensitive surgeries where we can defer it, better defer it. If it's not deferable, then we'll have to bridge. Very honestly, I've used bridging only in 2 patients, and both the patients have done well. And this was when the surgeon was just not willing to kind of, not do the surgery, and the patient was like, whatever happens, I'm doing it. So the choice was not left to us, and that's why we use bridging.
Thank you.
Another continuation. Are you concerned in stopping SAPT or DAPT after 6 months or 1 year for PCI or post-CAB?
So DAPT, you can definitely take away the second drug. We need to continue at least aspirin when the patient is undergoing. Most of the surgeries now, if you look at the guidelines, they allow use of aspirin. So in very few surgeries, especially when they are doing a spinal anesthesia or intracranial surgeries, and or transurethric prostatectomy, where the bleeding risk is high, is the only time probably you will want to stop aspirin for a few days. But otherwise, aspirin as such is recommended, and we need to continue it for all patients. So after 6 months, I think the new generation stents, especially if you're using the Xience family of stents, Onyx and or Biofreedom, we don't have here. So if you're using these 2 groups of stents, then probably you are really, honestly, we are safe. At 6 months, we are definitely safe.
Yeah, Dr. Uday.
I have 2 comments. One is about the antiplatelets. I would like to include anticoagulants also, because I belong to a center which is a tertiary cardiac center. It is only a cardiac center, and we have an everyday problem about this type of patients. So what we do is, we do not stop any antiplatelets. For dental, I am referring to dental, what you mentioned. We do not stop any antiplatelets, anticoagulation. We allow the patient to continue. When the patient is undergoing dental therapy, even if there is an extraction, the dentist puts a gel foam there and sutures it. So there is hardly any bleeding complication, as you said, Darwin's therapy, except for a selected few. And my second comment is regarding Dr. Pehlajani's presentation about normal coronary arteries. This comment is what I learned from my own problem. I was involved in a criminal medical legal case where a lady in her 30s came to me with extensive anterior MI. She had normal coronary arteries, so we told the relatives that she will settle down. In fact, she did not settle down. About 40 hours later, she died. Now the funny thing is that she had ST elevation in all the leads. LV function, there was no regional wall motion abnormality at all. So we said that it is because of the ST elevation, raised troponin, the troponin was about 1000. We called it a MI with normal coronary arteries. Ultimately, the patient died, was buried, and there was a case, so we had to exhume the body. And before, when we exhumed the body, we went through the literature. One case, there are few case reports of ammonium nitrate poisoning, which mimics global myocardial infarction with normal coronary arteries, and we cannot diagnose it even on the blood test, because by the time the patient presents as myocardial infarction, the ammonium nitrate has already passed away. And we have to take biopsies of the myocardium, see the ammonium nitrate assessment over there, and then come to a final conclusion. We got a tip-off from the college. She was a biochemistry demonstrator, and one bottle of ammonium nitrate was missing from there. And that is how we got a tip. We asked for exhumation of the body, and thankfully I was released. So that is one thing we should always remain. Remember, when there is extensive global infarction with hardly any wall motion abnormality. Thank you, sir.
Dr. Akshay, 1 minute. Yeah, it's quick.
You stop clopidogrel, say patient has undergone dental or whatever work after 3 months or 6 months, stop clopidogrel for 5 days or whatever. The surgeon has stopped it. When you restart, will you give a loading dose or not?
Yeah, the recommendation is to give a loading dose. You have to load the patient again with clopidogrel. Yeah.
Thank you, Dr. Amit, and we'll close the session. I thank our co-chairpersons and move on to the next session, Dr. Milind.